I'm Dr. Richard Aiken, a practicing oral and maxillofacial surgeon from Baton Rouge, Louisiana. I'll be demonstrating my technique for immediate provisionalization of an acutely fractured lateral incisor. Here you can see tooth number 7 and the associated abrasions on the patient's face. Here in the Panorex you can see that tooth number 7 was fractured, although we have good apical bone morphology. Here's a clinical view of the site with the fractured tooth number 7 and the periapical showing good apical bone volume, as well as a tangential fracture of the tooth subcrestal. Initially, after anesthesia is obtained, a number 15 blade is utilized to release the sulcular epithelium. The buccal plate is probed for evaluation, and a peritome is utilized to completely mobilize the retained root segment. This is performed so as to avoid any pressure on the buccal, and tooth is then easily removed with a forceps. Here the residual root is measured to help in obtaining the initial implant length. A ultrapulsed CO2 laser is then utilized to remove any sulcular remnants. And here I am using a probe to evaluate the socket and the buccal plate anatomy and comparing that to the adjacent teeth. A shade is selected and the initial drilling sequence begins. The noble active system is being utilized in this case, and you can see perforation through the apex of the residual root and stopping at the nasal floor. Periapical is then obtained to visualize the initial drill in place. Here's a clinical view showing the optimal trajectory of the implant in this location, which is to the lingual aspect of the alveolus. In this case, I utilized bone putty with cancellous chips, and this is packed into the socket. The noble implant that we'll be using is selected, and it is placed into the putty graft. The graft is displaced out the buccal, and the implant is then seated to full depth with a torque driver. A periapical is then utilized to evaluate the implant insertion depth, and an Ostel ISQ device is used to perform Ostel readings. This is the placement of the Ostel peg. In a case such as this, where we achieved approximately 70 Newton centimeters of insertion torque, we would expect there to be a high ISQ value, and in this case the ISQ value was 68, with a value of 60 to 65 signifying clinical implant stability. Next, abutment selection takes place utilizing a zirconia abutment kit, which provides a number of different types of zirconia prefabricated abutments. The selected zirconia abutment is seated and a periapical is taken. Next, the abutment is tailored for the site. A vacuform matrix is used to fabricate the provisional. A duplicate of the abutment is used to finish the margins of the provisional. Here are the margins roughened out, and you can see in the next photograph the completion of the provisional. Note the submergence profile of the provisional near the gingival margin. And here you can see the placement of xenograft into the buccal gap. Ferment is then utilized to seal the access hole, and this is light-cured into place. Next, a final radiograph is taken. At this point, occlusion is verified, and note that the provisional, when the patient goes to excursive contact, is slightly in contact, and that will be relieved. Here's a final view of the provisional and the conclusion of the procedure. Here's a close-up view of the tissue support and site after the provisional and at the completion of the procedure. Here is a 6-week follow-up photograph. You can see the supported gingiva and the excellent papilla fill in this area. Typically, I will see patients back 2 weeks, 6 weeks, and 3 months after this type of procedure. In this patient's case, he had failure of the cement at approximately 8 weeks, and I took a photograph of the provisional removed. You could see the margins have held up well. And in this case, I utilized ProTemp and composite at the margins of the temporary. Here's a clinical photo of the site just prior to impressions. The temporary has been removed and the ferment is still in place. I enjoy clinical photography in my practice, and this demonstrates one of the reasons why, especially when we have a very compliant patient who strictly adheres to all the postoperative instructions. Sometimes they will cease cleaning in the interproximal areas, but in this case, patient had stopped flossing, and often clinical photography can help me pick up on these things and make sure I address them in future patients. Here's the final periapical of the area. This is approximately 3 months after placement and just prior to cementation. Here's a clinical photograph after final crown delivery and cementation. Patient was ecstatic with his results, and I have found a very high patient satisfaction level with this procedure. More importantly, the clinical outcomes have been by far some of the best I've seen, as opposed to 2-stage procedures. Of course, this depends upon bone morphology of the area, the gingival architecture, and patient compliance. Also, the overwhelming majority of patients would rather this procedure than having to undergo multiple procedures and wear a removable device during an extended period of time. Thank you.